Hi everyone, it's Naveen again. Today's topic is chloride deficient metabolic alkalosis. All of you have heard of this in some way, but you probably know it under a different name, and that name, which I really dislike, is contraction alkalosis. And my goal from this video, if anything you take out, is that contraction alkalosis isn't a thing, and it's chloride deficient metabolic alkalosis. And I really want to underpin the physiology of this because contraction alkalosis presupposes a different pathophysiology that ultimately leads to the inappropriate treatment. So let's take two examples and then understand the physiology behind why metabolic alkalosis truly develops in these patients who also seem to be volume contracted. We see patients that have nausea, vomiting chronically, or have been diuresed for a long period of time. Say you're a heart failure patient that's being diuresed, or you're lung patients with ILD that you're diuresing for a long period of time. And over time, they develop a metabolic alkalosis. And I even have heard people say, okay, let's diurese until a patient develops a metabolic alkalosis, then you know that you've overdone it. And that doesn't seem to actually match clinically, especially in our heart failure patients. Oftentimes, these patients clearly have volume. You can even do the right heart cath and they clearly have volume. So, why do they have a metabolic alkalosis? Well, we'll get to that in a bit. But now let's take a patient with chronic diarrhea, some sort of infection, maybe IBD, something like that. These patients, we all know, develop a NAGMA, a non-antiget metabolic acidosis. Both these groups can come in with an acute kidney injury, right? And they can have an acute kidney injury with metabolic alkalosis or chronic diarrhea with a non-antiget metabolic acidosis. That means they're actually both volume contracted, but they don't both exhibit metabolic alkalosis. This should be the first clue that the pathophysiology of volume contraction or contraction alkalosis is incorrect. Contraction alkalosis. Let's draw a renal tubule and try and understand the actual pathophysiology that's presupposed by the term contraction alkalosis versus the true pathophysiology that is defined by chloride deficient metabolic alkalosis. So we're going to draw a nephron here. And let's zoom in to the area where aldosterone is working to maximum, and that's this region here. So in this region, you have multiple cells called the principal cells, the alpha intercalated cells, and the beta intercalated cells. They each have different functions. The principal cells are the cells that carry your ENaC channels and your ROMK channels, which are your sodium and potassium channels that exist in the collecting duct, and are regulated by aldosterone. There's a MRA receptor here that regulates the expression of these. And what this does is ultimately leads to sodium absorption and potassium excretion via these two channels to maintain electroneutrality. The sodium absorption's goal is to try and improve our volume status when we're in a volume contracted state. Now, as the potassium moves through the alpha intercalated cells, you also see transport of potassium back into the cell, and in return, you see these hydrogen ATPase and other transporters of hydrogen that allow hydrogen to leave the cell and into the urine space. And so then we ultimately excrete the hydrogen. Now what happens here then is because hydrogen is being excreted out, bicarbonate is kept and sent back into the serum system, and so we assume that this is where our alkali load is coming from. Okay, so our alpha intercalated cells are our acid secreting cells that in an aldo state are going to be excreting hydrogen protons and then generating the bicarb that maintains the metabolic alkalosis. This is the presupposed physiology of contraction alkalosis. Now, this starts to fall apart when we really understand that in contraction alkalosis, or in a high RAS state, we see that actually we ramp up our absorption of sodium, especially in our proximal tubule, our ascending limb, and our distal convoluted tubule. That actually leaves very little sodium reaching the very distal portions of the nephron. And if very little sodium is reaching the distal portions of the nephron, there is no mechanism to generate this series of processes that occur in order to excrete hydrogen. Okay? More importantly, if we don't take that pathophysiology by itself, this has been studied in multiple studies, both human and animal models, that showed that the metabolic alkalosis can be persistent despite the level of aldosterone, whether or not it's low or high. One rat model has been done where they did adrenalectomies in these rats and showed that you could still develop a chloride deficient metabolic alkalosis. You could still develop a metabolic alkalosis by quote unquote volume contracting the patient. But these rats don't have aldosterone, and so how can that be if they don't have aldosterone? Well, that tells us that there's a different mechanism at play here, right? Okay, let's go back to our nephron and then talk instead about the chloride deficient metabolic alkalosis, which is the true mechanism. So in chloride deficient metabolic alkalosis, what happens is the effect is really coming from these beta intercalated cells. There is an exchanger in the beta intercalated cells that allows for chloride absorption and excretion of our bicarbonate. In chloride deficient states, a few things happen, and we'll talk about that pathophysiology in a little bit. But one of those things that happen is that there is no ability to exchange chloride here for bicarbonate in this exchanger. This exchanger is called pendrin. Pendrin was the name of a person who I think first characterized this. But this pendrin transporter did not allow for exchange of chloride and bicarbonate, meaning that bicarbonate starts to maintain itself in the serum. This is the true mechanism and pathophysiology of the metabolic alkalosis that develops in volume contraction. Rather, it's not related to the volume contraction itself, but if we think about those cases, nausea, vomiting, and overdiuresis, these patients also have significant chloride losses, whether that's nausea, vomiting from the gastric contents, or that's the overdiuresis over a period of time leading to sodium chloride losses in the urine. And the salt restriction that we often put on these patients leads to a low net loss of chloride over time and a total body chloride depletion. This leads to the metabolic alkalosis. And we can think of other mechanisms in the blood that would maintain this. For example, chloride is negatively charged and bicarbonate is negatively charged. And so in order to maintain electroneutrality, if we become total body chloride deficient, we have to increase our serum bicarbonate and start pulling bicarbonate from stores in our body in order to maintain that electroneutrality, right? So we have multiple mechanisms here that explain chloride deficiency and bicarbonate. All right. Now, similarly to these models where we talked about animals and humans and showing that aldosterone is not the main mechanism, we have plenty of experiments where instead chloride was administered into these patients, and bicarbonate then starts to decrease when we do that. All right. One really extreme example of this was an experiment where they took humans and they purposely suctioned gastric contents in order to cause severe, losses of electrolytes that included hydrogen and chloride. And this ultimately developed chloride deficient metabolic alkalosis. And it wasn't and what they did instead in order to maintain euvolemia was replenish a fluid that had all the electrolytes minus hydrogen and minus chloride in it. So these were the only two that they did not give back. Okay, and when they replenished this, these individuals had a state where they were relatively euvolemic, but they had this metabolic alkalosis. And this metabolic alkalosis would not correct until chloride was re-administered to the patient. Okay, and so we have other models and other experiments that evaluate this, but it's been pretty well borne out in the literature that it's the chloride deficiency that drives this metabolic alkalosis, not the volume contraction. And the clinical example that I gave earlier is that in patients with diarrhea where there's not so much in chloride losses, because diarrhea is a very hypotonic fluid with not a significant amount of chloride, um, they develop a non-aggregate metabolic acidosis. They don't develop a quote-unquote contraction metabolic alkalosis, right? Okay, but let's talk about um, some of the things that maintain a chloride deficient metabolic alkalosis and the effect of chloride deficiency on the renal tubule and why it matters, especially when we're diuresing patients, and how we can use our understanding of this physiology to treat our patients clinically more accurately than we would if we presuppose the definition of contraction alkalosis. So this has been also borne out in the literature for many, many years. It turns out that chloride deficiency leads to increased sodium avidity. How does it do that? In numerous portions of the tubule, we have a family of transporters that are sodium, potassium, chloride cotransporters, and sodium chloride cotransporters. The macula densa also shares the sodium-potassium chloride cotransporters. It turns out that when we exhibit chloride deficiency, there's a pathway that ultimately leads to increased expression of these transporters at the cell surfaces. And that leads to increased sodium avidity. So sodium starts getting absorbed and we start to experience diuretic resistance. What does that mean? Well, when we use diuretics and you see less and less output, not because their volume contracted, but because there's less chloride. And so this leads to an overactivity of these sodium avid transporters. Chloride also regulates our RAS. And when chloride is low, RAS increases. And so we have a neurohormonal activity that also feeds back and increases our activity of our sodium transporting transporters and increasing sodium avidity. Okay. And ultimately, what I'm trying to say is that chloride deficiency leads to severe diuretic resistance. This is going to cause you to run into trouble where you start to see creatinine rises and decrease urine output. Why is that? Well, RAS being active, for example, is going to modulate the blood flow that we see going into the kidney. And if the blood flow is going into the kidney starts to decrease, well, we start to see less filtration through the glomeruli. Less filtration through the glomeruli means that creatinine and BUN will start to go up because they're just not being filtered. It's not that the tubule is not working, it's that the tubule is doing its job responding to the neurohormonal environment and transporter expression that is supposed to be doing based on the physiology of the person. Okay. But chloride isn't the only thing that often is the problem in these situations. It turns out that potassium is something that we also have to address in these situations. Why is that? Well, oftentimes in our chloride deficient states, for example, let's take our nausea, vomiting, or our diuresis states. We lose chloride over a period of time, but we also lose potassium over a period of time. And it turns out potassium regulates and maintains metabolic alkalosis. Why is that? Let's redraw this renal tubule one more time and talk about why potassium maintains metabolic alkalosis. So drawing the renal tubule, we really care about the proximal tubule here. In the proximal tubule, it turns out these proximal tubule cells are pH sensing. Now, if we take our serum side, here, I'm drawing it in red for blood, okay, and we have low potassium in our blood. Well, what happens is our intracellular stores then move potassium out of the cell in order to try and replenish what's missing in our serum. In return, hydrogen then moves into the cell because these are both positively charged. And so potassium leaves the cell, hydrogen moves into the cell. The intracellular space, the pH starts to drop. So the proximal tubular cells, sensing that the pH intracellular is dropping, believes that there is an acidosis that needs to be dealt with. So what it does instead is it starts to secrete ammonia, increases its generation of ammonia. Now this ammonia binds hydrogen protons that are released via hydrogen ATPase or sodium hydrogen exchangers, multiple hydrogen transporters here. And this creates your NH4 carrier that stays in the urine, and ultimately we urinate proton, right? We urinate proton via NH4. Well, what happens when we urinate proton? By urinating proton, what must remain in the serum is our bicarbonate. And so we ultimately develop or maintain here a metabolic alkalosis. So in many settings of quote-unquote contraction alkalosis or chloride deficient metabolic alkalosis, we see a dual loss of chloride and potassium, where chloride is the thing that generates the metabolic alkalosis, but potassium is what maintains, hypokalemia maintains this metabolic alkalosis. Why does this matter? Again, for the same reasons, for the same reasons, this leads to a decreased efficacy of our diuresis. Potassium also regulates our sodium transporters and similarly increases our sodium transporter activity, and so you get increased sodium avidity. So this combination of metabolic alkalosis, chloride deficiency, and hypokalemia, this triad here, increases diuretic resistance and is the enemy, the bane of what we're trying to achieve when we're trying to diurese a patient in the intensive care unit. Now, more and more data is pointing to the importance of decongesting, especially after our initial resuscitation period. I think we're very poor at knowing when to transition to decongestion. The key over the next years will probably be determining how to appropriately decongest, and I think it's an important skill to know to decongest. Now, aside from even that, when you feel more comfortable decongesting, this could be a patient with ILD or heart failure. You really need to be aware of this physiology, because what I don't want people to think is, oh, creatinine is going up. Oh, bicarbonate is going up. That means that we're achieving a volume contracted state. This couldn't be farther from the truth. This is not how you should approach diuresis. This is not where you stop diuresis. This is where you ask yourself about the physiology and have you appropriately addressed it. Now, I want us to recognize that there are multiple trials out there that also suggest that creatinine bumps during diuresis is not necessarily associated with all worse outcomes. Yes, it's associated with increased mortality, but it's also associated with decreased readmission rates in the hospital in those who survive, probably because it probably means they were decongested, and it also might be a suggestion that creatinine is just concentrated once we've removed excess fluid from the body. Okay, so please don't think of the term diuresis to AKI. Don't think of diuresis to bicarb or alkalosis. These are not appropriate measures of volume state. This does not replace your volume exam. This does not replace, does not show does not appropriately reflect the physiology that the patient's experiencing when they're being diuresed. Okay, so let's go into a couple scenarios of where this is important. The first one is a more straightforward one. I think the second one is going to be one that those of you in the intensive care unit are going to find more interesting if you're pulmonary trained. So scenario one, Let's change colors really quickly. Scenario 1 is just diuresis. Diuresing in the ICU, the decongestion phase, okay? So you have a patient who came in with septic shock. They have a history of heart failure, ejection fraction of 30%. You gave them fluids. You treated their GNR bacteremia. They're improving on day 3 or day 4, though. What you start to see is that they're appearing puffy from all of that. Their blood pressures are better. They're off pressors, so you start diuresis. So let's say day 1, HFrEF and septic shock. You resuscitate plus antibiotics, and then you get to, say, day 3 or 4, improvement in pressors, but congested, right? And so now you start your diuretics. Start diuresis, and then on, say, day 5 and 6, because this patient has had poor nutrition this whole time, you start to see a creatinine bump already. So creatinine goes from, it was 1.2 and it goes to 1.4. You see BUN going up perhaps. You see the bicarb is 32 in this patient, and you start to wonder, okay, am I volume contracted now, right? And you look at the patient and they got pitting edema. They have and you're like, there's no way they're volume contracted. That doesn't make any sense, right? It's because it's the low albumin. Well, no, probably not. It's probably not the low albumin of 2.8. That's probably not what it is. It's just that we have to understand the physiology of these patients, right? What I would do in this situation is recognize our physiology when we thought about our nephron. These patients who have protein caloric malnutrition, right, are being diuresed, and the patient was probably on diuretics outpatient. What's happened is they're in a chloride deficient state. And that chloride deficient state is leading to sodium absorption in all the places, particularly through the RAS and neurohormonal methods. And so you're experiencing decreased blood flow. And by decreased blood flow, because of the constriction, you're seeing that the creatinine and BUN are going up. So how do we fix this situation? How do we turn off the neurohormonal axis? Well, the key is giving chloride. Key is giving chloride. And then we talked about how hypokalemia maintains the metabolic alkalosis. So we also have to give potassium. It turns out there is a great drug for this. And that drug is potassium chloride. When you diurese a patient, you should consider a K less than 4.0 the enemy, a failure. Okay? If you have a K of 3.9, you're not giving enough K. And so even if they have an acute kidney injury, even if they're not doing so, you're worried about giving potassium. Instead, change your K target to greater than 4.5 and aggressively give them K. Okay, I'm saying give 10 MEQs per 0.1 deficit plus some. Give potassium chloride. Now the benefit is that it also gives a very nice significant chunk of potassium chloride, okay, and a chloride as well. And so you address the pathophysiology with a drug that we're very comfortable using, potassium chloride. Now it's really funny because potassium chloride actually contains a very significant milliequivalence of chloride. And we're really used to saying, okay, it's okay to give 60 MEQs, 80 MEQs of potassium chloride. But we sort of run into issues with things like 3% saline that we're going to talk about in a very, very short bit. But let's say you are doing a good job keeping the K above 4. So it's day and your K is 4.2. You're trying to get it to 4.5, but you're still struggling with the bicarb or something like that. Well, how can we try and fix this? Well, this is where we might add spironolactone. I don't care what the creatinine is doing, but maybe add spironolactone 25 or 50 milligrams. Yes, not the 12.5 that we, might use in cardiology to start with a peak at 25. No, use a nice dose of 25 or 50, and we can go up. Primary hyperaldo, you can see up to 400 milligrams per day. So spironolactone is often being underutilized in many of our situations. But let's say we use 25 or 50 to start. What is the benefit of this? Well, spironolactone blocks the aldo system. I told you aldo is not the important part for maintaining or creating a metabolic alkalosis, but it still has the nice effect of reducing, preventing K excretion, right? So potassium is no longer going to be excreted, and its other side effect is creating a mild metabolic acidosis. This helps reduce two of the factors that cause diuretic resistance, hypokalemia and metabolic alkalosis. Not so much the chloride deficiency, but it helps otherwise with the other two components. The other thing then you can add is acetazolamide. The nice thing about doing this is we know that diuretic resistance also includes hypertrophy of other segments. We might be using loop diuretics, but instead what we do is increase the hypertrophy other segments of the nephron that lead to increased sodium absorption because of the deficit that we're seeing in the ascending limb of the loop of Henle. So by using acetazolamide, we can then allow for bicarbonate losses, which is an additional diuretic via the form of sodium and bicarbonate, right? And so we'll fix our bicarbonate slowly, roughly 2 per day if we're using 500 milligrams of acetazolamide. And so my approach here in diuresis would be a combination of KCl with a K goal greater than 4.5, adding spiro early, and adding acetazolamide. Now I will say, once the metabolic alkalosis has been created, spironolactone does not uh, correct the metabolic alkalosis, does not correct, but it does help prevent. On the other hand, acetazolamide does correct the metabolic alkalosis, okay? And so I would use this combination here in addition to our loop diuretic to try and correct this chloride deficient metabolic alkalosis that we're experiencing and reduce diuretic resistance, okay? All right. That's scenario one. I think this is the straightforward, hey, this is a patient who's being diuresed. What is my approach to diuretics and avoiding contraction, this quote-unquote contraction alkalosis that we now know is metabolic, chloride deficient metabolic alkalosis, right? Regarding scenario one, I shared my general approach to how I diurese a patient with a combination of KCl, spironolactone, and acetazolamide. But I actually want to share something else that I think we need to be pulling out earlier, and that's hypertonic saline for diuresis. And what is the mechanism of this? Well, let's go back and do a little bit of fun history. Back in the 1950s, we used to use mercurial diuretics. Right, that sounds healthy. On top of many, many, many side effects, something that many patients who didn't, have the poisonous effects of mercury get, they experience this syndrome called low salt syndrome, where they would have hyponatremia and hypochloremia and become diuretic resistant. You'd all automatically see these patients just struggle to urinate. So in 1956, this experiment was done where they purposely created a metabolic acidosis and increased the chloride in these patients, and saw that when they did this, all of a sudden they would respond to the mercurial diuretic again. And so they suggested that perhaps even at this time, this chloride deficiency, this metabolic alkalosis, this low salt syndrome was a state of diuretic resistance. If you fix the low salt syndrome, they become diuretic responsive. In the 1990s into the 2010s, this was taken a step further by multiple randomized controlled trials that got larger and larger, the largest one being a 900 versus 900 group randomized controlled trial where they did 3% saline plus diuretic versus standard diuretic alone. They did use some really weird doses of diuretic. They used something like 250 milligrams IV BID of Lasix. But other trials have come out using more reasonable doses and also different ways of evaluating the mechanism of all this, of what I'm about to say. So despite this weirdness, it is probably true, at least that's what I think, that 3% saline was associated, this arm was associated with more diuresis, lower creatinine, better GFR, right? So, and then better mortality. So they had lower mortality plus readmissions. And I think this data really can't be ignored. The average sodium in this patient population was actually a sodium of 137. Okay, and so in patients who are normonatremic to hyponatremic coming in with this metabolic alkalosis, I suggest that the moment you're diuresing them, even with a loop diuretic of 40 or so, just throw on the 3% saline. You're thinking, okay, what dose do I use? Well, they used 150 milliequivalents of 3% saline BID. Sorry, not 150 milliequivalents, 150 mLs of 3% saline. I'm sure 100 mLs of 3% saline our institution, since it's sort of capped at giving that at a time, is okay. Another situation that I think would probably work as well, and especially in a hyponatremic patient, is a 3% drip at a low dose. I've used this actually a couple times while treating hyponatremia to good effect and seen a significant increase in urine output. And I think in general that I've seen that renal function seems to be a lot better. One study actually evaluated a 24-hour creatinine clearance in these patients and saw that in the patients getting standard diuresis with loop diuretic of 40 milligrams, their baseline GFR is 43 versus 42. Just loop diuretic alone saw a creatinine clearance of 37, and then when they gave the 3% saline, the creatinine clearance in the next 24 hours was actually 63, which is a pretty big increase. But this is borne out in other literature suggesting creatinine seems to be better in the groups receiving 3% saline. This probably all has to do with chloride's effects on the neurohormonal axis and sodium avidity and decreased blood flow to the kidney, right? To the nephron unit rather specifically. And so argument here would be hypertonic saline for diuresis is an adjunctive therapy that really should be considered more frequently. And the literature to support is this chloride deficient metabolic alkalosis and everything that we see. All right, scenario 2 is the scenario that I think many people with pulmonary diseases are going to, or who deal with pulmonary disease are going to enjoy. So you have your patient with OHS or COPD or something like that, plus heart failure, and their baseline pH is something like 734. PCO2 of 62 and a bicarbonate of 31. Now you diurese this patient for a period of time, and unfortunately their pH becomes 7.5 with a bicarb of 40. And you start to worry at this point, okay, what do I do? Their bicarb's really high. Do I stop diuresis? They've clearly got volume on them. They're not breathing any better. We need to keep going. What do I do? Right? And so the question frequently becomes, do I give acetazolamide? But if I give acetazolamide, is that going to be too strong? How do I make sure that I don't overcorrect them because I know they do have a baseline metabolic alkalosis? I don't want to correct them to normal. Well, multiple studies have evaluated acetazolamide in this context, and the general dose in these studies was 500 milligrams PO daily, and saw that this roughly led to a 24-hour change uh, in bicarbonate of -2 milliequivalents per day. What I would do is we need to get used to doing some math here. What I would say is that we need to recognize what their baseline state was. We need to recognize what their bicarb at baseline is. If that'd be even better to skip a little bit of math. And then our argument would be, okay, no, we gotta give chloride back to these patients. Let's target a K greater than 4.5. Let's even consider spironolactone. And let's do acetazolamide. Right? Let's give acetazolamide with the expectation that 500 milligrams per day will drop us by this amount, right? And then say that doesn't work, the next day we increase it to 500 BID or 1000 BID, and we can keep going as necessary in order to achieve our goal. But when we hit our bicarbonate goal, then we pause there and we just keep giving our potassium chloride, and continue diuresis, trusting that the rest of the metabolic acid-base status is going to be maintained by our kidneys, that as long as they have adequate access to potassium, to chloride, and volume, right? Which, presuming they truly are volume expanded, they have access to that volume, right? So my approach in this type of situation is everything I mentioned in scenario one, but more intentionally trying to purposely get our bicarbonate back down so that we run into less issues uh, with the chronic respiratory acidosis later. Just be more intentional about the number we're trying to target, but not be afraid to target that number, right? Okay, well, thank you so much for listening to this episode. Please let me know if you have questions. In particular, I did bring up a lot of data. If you have any questions about what that data specifically is, feel free to message me and I can share that data with you directly. Um, so, or in the comments below. Thank you.